My name is Haifa Kathrin Al-Ali. I am a hemato-oncologist working at the University Hospital of Halle in Germany. And it is really my pleasure to present the data of a combination trial with both BET inhibitor and a JAK inhibitor, which will be presented on behalf of all the co-authors at the ASH meeting 2023. The rationale for this trial was that, as we know all, that JAK inhibitors are the standard of care, but with all the efficacy results we know now for years, there are still many limitations, particularly the loss of response. So it is always important to find new ways to try to improve the outcome of patients with myelofibrosis. And the rationale for combining such a JAK inhibitor with a BET inhibitor is actually to use a new and novel epigenetic modulation to try to regulate gene expression, as we know very well that in myelofibrosis, it is very often that bromodomain proteins are increased, and they are really causing, under other reasons, a lot of expression of cytokines such as TGF-beta, and this all worsens the pathogenesis of myelofibrosis, particularly the fibrosis. So the rationale for a combination is given, and in this phase 1, phase 2 trial, the BET inhibitor of BMS, which still doesn't have a name, only a number, is combined in first-line treatment with ruxolitinib in patients with myelofibrosis who have not received a JAK inhibitor yet, but also a second-line treatment option for patients who have prior ruxolitinib exposure, where the BET inhibitor is combined with fedratinib, another JAK inhibitor. The phase 1 data, sure, are mainly there to see the efficacy data and to identify the optimal dose for the phase 2 trial. And today we will and in this session we will present the phase 1A data, combination BET inhibitor with ruxolitinib, and also second-line treatment data, BET inhibitor plus fedratinib. Overall, patients' number are still small. In the second-line treatment, we have 32 patients. In the first-line treatment, around 18. What we could say, and I think this is very important, is that more than 80% of patients, after a median follow-up of 53 weeks, are still on first-line combination treatment, and also around 80% are still on treatment after a median follow-up of 24 weeks. This shows that the tolerability of the combination is quite acceptable. Main adverse events are thrombocytopenia, as would be expected. It is more in the first-line treatment than the second-line treatment, and I think this is an expected dose-related off-tumor effect of the BET inhibitors. They are transient and reversible with the dose reductions or dose withholding, and no patient in the first-line treatment was discontinued because of thrombocytopenia. Only one patient in the second-line treatment arm was discontinued because of thrombocytopenia. Additional adverse events would be, as we know, some GI toxicity, but this was also manageable in the majority of patients. To efficacy, still it is very preliminary, and we could see really very nice spleen volume reductions in the majority of patients of both first and second line. But as I said, these should be interpreted with caution because the number of patients is still small, and data to total symptom improvement will be presented later. So in conclusion, we could say that the combination of a BET inhibitor with a JAK inhibitor, both in the first-line setting and in the second-line setting, is a reasonable approach and might improve the outcome of patients with myelofibrosis.